Hey YouTube family, happy Sunday. Oh wow, it's been a bit of time, not super long, but a bit of time. So I'm so grateful to be back to share with you guys what the endocrine system is all about for the NCLEX. Okay, not everything about the endocrine system, but what the NCLEX focuses on. Those two glands of the endocrine system that the NCLEX focuses on. Okay. Before I get into that, I want to say thank you to my 21 subscribers. When I saw that this morning, it motivated me to even do this video because I'm like, wow, so people are following. So people really like what I'm doing. At least I thought that initially I said to myself, if this or whatever I'm saying here can help even one person, I'll be super, super grateful. But it has helped 21 people. They're subscribing and the subscribers keep coming in every day. I'm so blessed. I'm so grateful. Thank you so much. And please, if you haven't subscribed, please just do that because like I said, this channel is not just going to be about the NCLEX. There are so many more exciting things that I will share with you guys, my journey, so many things that I have to share with you guys because like I said, you're already like family, and as family we share. So I have so much in store for us, and of course, you can have contributions in my life as well. You being family already is a huge contribution. I don't know, you might be an uncle, an aunt, you might be a sibling, you might be whoever. I mean, I'm just giving you guys the names now because you feel like family to me already. Like the 21 people I saw this morning, I was like, oh, thank God. I'm going to do another one because it's helping not just one person, but it's helping about 21 people. So please, don't forget to thumbs up the video because if you thumbs up, the more you thumbs up the video, the more other people get the chance to see it. You know, there are so millions of things on the internet, on YouTube especially, and I know I'm not even close to close to the best because look at me, I just sit here and talk to you guys. There is nothing exciting. So I'm not even close to the best, but at least it's helping someone. And don't forget to like it, to share it. If it helped you with one thing, you know, the difference between passing and failing the NCLEX might just be one single question. And maybe you're gaining that knowledge from here to be able to ace that one single question that makes or that will make a difference in your NCLEX story. So, in that light, don't forget to share it. There's someone out there that just needs one question to top it and go above that pass line and just nail it. All right, so without further ado, let's go into the meat and the potato of today's lecture, which is the endocrine system. Okay, so the NCLEX doesn't they do not focus on the entire endocrine system, which is why we will be talking about just two glands in this endocrine system, which is the thyroid and the other one, which we will see later. Okay, so we will start with the thyroid gland. So one thing I want you to know before we get into the lectures is that whenever you see the thyroid gland, okay, when you see a question that talks about the thyroid gland, the first thing you should sit back and do is convert everything you see about the thyroid to metabolism. Why is it so? Because the thyroid helps to regulate metabolism, right? So when you see thyroidism, it's safe to say it's metabolism. Thyroidism, metabolism. It's safe to say that because what does the thyroid do again? It regulates metabolism. So whenever you see thyroidism, translate it to metabolism. You are good to go. So in that same understanding, when you see hyperthyroidism, safely say this is hypermetabolism. Okay? So, like I said, the first one is hyperthyroidism. So, hyperthyroidism, aka hypermetabolism, or Graves' disease, because the NCLEX will mostly call this Graves' disease. Graves, as in running yourself to the grave. Graves' disease, okay? So, what is hyperthyroidism? This is when your thyroid is secreting too much of the thyroid hormones, that metabolism is just super, super, super hyper, just from the word hyper. Okay, so when this is happening, it's called Graves' disease or hyperthyroidism or hypermetabolism. Okay, so what are the things you will see in someone who has this condition? Think about it. If your body hypermetabolizes, what do you expect to look like? Skinny and they lose weight. So that's the number one sign and symptom you see with these people. They are very skinny and they lose weight. Okay, another thing you will see with them is that since they are hyper, most of the vital signs will be high as well. Most or all, they'll have high heart rate, high blood pressure, high respiratory rate, and they will be high as the word hyper. So when you see a question on this, just think of everything being high, okay? Another unique sign you see with them is exophthalmos, which is bulgy eyes. Their eyes will be bulgy, okay, as if they will come out of the socket. So that's one thing you see with them. Another sign and symptom that you see with these people is, take note because this one, it's always like a fetal part as well. Remember, we're talking of hyperthyroidism, and I just listed a few signs that you see with these people. And now I'm about to talk about another sign that is so important that you take note of. These people are hyper. So if they are hyper, what happens? They cannot tolerate being hyper. So they are what? Heat intolerance. Because they are hyper. Look at someone who is hyper as someone who is hot, right? So if you're already hyper, you cannot tolerate being hot again. So they are heat intolerance, but they are cold tolerance. You get that? So commit it to memory because you see that somewhere. Trust me. And then another thing you see with them is sweating. Of course, I said they are hyper, so you definitely expect them to be sweating a lot. And many more. But everything that is centered around them when it comes to signs and symptoms, you just have to look at it like hypermetabolism. When your body hypermetabolizes, what do you expect to see? Of course, this will guide you to answer these questions, okay? And then, so this is not something that is pleasant for someone to live with, okay? Nobody has to live with this condition, which is why we have 3 ways to treat this condition. And the first way to treat it is using radioactive iodine. You will see this a lot as well. When I was doing UWARD, I always see this treatments for hyperthyroidism or Graves' disease a lot, okay? And even in the exams, you see it in one way or the other. So using radioactive iodine to treat hyperthyroidism. That sounds interesting, but there are some things that you should take note of before you put the patient on this kind of treatment for Graves' disease. The first thing is this: if it's a woman of reproductive age, this woman you must do a pregnancy test, okay, and confirm that it's negative before this woman undergoes radioactive iodine treatment for hyperthyroidism. If a pregnant woman has hyperthyroidism as a problem, you dare not use radioactive iodine to treat them. Okay? So, if they come to you and they say that, if they come to you and you have this treatment to administer, just make sure you do pregnancy tests, not just one, not just two, maybe 3 pregnancy tests to confirm a negative pregnancy before you go ahead to administer radioactive iodine to a female of reproductive age. Okay? All right. And another thing is their urine. Their urine is so dangerous. So when someone undergoes this treatment, you should keep them in a separate room If they are at the hospital, they should be in a separate room by themselves, and they should use their own bathroom by themselves. And when they use it, instruct them to flush it like 3 times. Flush their urine like 3 times, not even like, I mean, flush their urine 3 times whenever they use the bathroom. Remember, they're in a room by themselves and they're using a separate bathroom, and they're flushing this bathroom. Each time they pee, they flush it like 3 times. Radioactive iodine is not something to play with. Okay, remember, I said they should be in a separate room, they should flush their urine 3 times, they should avoid coming in contact with kids or with pregnant women. So if you treated someone using radioactive iodine, instruct them to stay away or avoid coming in contact with kids and with pregnant women. Also, when you're doing laundry for these people, it's good to separate their own laundry stuffs, and then you do it in a different cycle. Do not mix their clothes with other people's clothes. And these things you're avoiding will go from the day this treatment was administered to 1 week. So from day 1 to day 7, you have to do this. That gives them enough time for this iodine to leave their body, for this radioactive iodine to leave their body. Okay? So please commit those to memory, because you see them in your exams in one way or the other. And if their urine even spills on the floor, do not just come with your little rag and stuff to clean it, because you're in danger. You have to call the house MAC team to do this. It's not your job to do it. Don't just call the housekeeping team, call the MAC team. There are people who are specialized for this, and they will come in protected and they will do the right thing. Okay, so that's the first way you treat hyperthyroidism, aka Graves' disease, aka hypermetabolism. The second way is you use PTU. PTU stands for propylthiouracil. Okay, you use this to treat Graves' disease or hyperthyroidism. And this drug is primarily used to treat cancer. It's primarily used to treat cancer. So when you hear that, what does it tell you? It tells you that it can destroy or bring down your white blood count. Remember, drugs that are used to treat cancer, what do? They cause these people to be immunodeficient or immune depressed or immune suppressed. All of those words that you can put them together, but understand one thing. This PTU drug is primarily used to treat cancer patients, and I'm just trying to relate the knowledge so that you know that if you're using this drug to treat a patient who is hyperthyroid, expect that their white blood count will drop drastically. So as a nurse, you need to keep an eye on their white blood count. Okay? All right. And you have to watch out, because these people, they have now a weak immune system, so you need to make sure they do not get any kinds of infections. You need to keep them away from all sources of infection, or try as much as possible to protect these people from acquiring any opportunistic infections. The third most interesting way to treat hyperthyroidism, aka Graves' disease, is thyroidectomy. Here you will find questions, whether you like it or not. Thyroidectomy. Just from the word thyroidectomy, you already know that is the removal of the thyroid gland. But there are it could be in 2 different ways. It could be a total removal of the thyroid gland, which is called a total thyroidectomy, or a complete thyroidectomy, or it could be the removal of just parts of the thyroid gland, which is called a partial thyroidectomy or a subtotal thyroidectomy. Okay, commit that to memory. So we will look at total thyroidectomy. which is also called a complete removal of the entire thyroid. Please pay special attention to these things because you see them, trust me. Total removal of the thyroid is called total thyroidectomy. Okay, so here the entire thyroid is taken out so that you'll be free from the signs and symptoms of a hyperthyroid person or Graves' disease person, right? So they just take out the entire thyroid. All right. So what do these people need to do? They need to live their lives on a long life hormone replacement therapy. That's what they have to do. Because guess what? The thyroid is used for what? Metabolism. Okay? Even though there is hyperthyroidism, it doesn't mean that you should get rid of the entire thyroid because you still need this to metabolize. But now that the thyroid has been totally taken out, completely taken out of you, what you need to do is you need to be taking thyroid hormones every day of your life. A long life term hormone replacement therapy. Don't forget that. The common one, of course, is um what's the name of that thyroid medication again? Okay, I will find it. It skipped my mind. Okay, so they will have to live on that for the rest of their lives because they do not have a thyroid anymore like you and I. Okay, so they will need that. And so there's one interesting thing that happens when a thyroid is completely taken out. Okay, there's one thing that happens when a thyroid gland is completely taken out. This patient has the risk of hypocalcemia. So this is a big concept. It's not just as easy as you hear it. Let me explain. So when the entire thyroid is taken out, okay, why do patients run the risk of hypocalcemia? This is the reason. You know, your thyroid anatomically is closer to the parathyroid. Okay, they are close together, and the parathyroid has a job. The job of the parathyroid is to regulate, is to increase calcium levels in blood whenever they are low. You get that? The parathyroid is to increase calcium levels in blood. Okay, let me take you back. Now, when the entire thyroid gland is taken out, it's very difficult, almost impossible to take out an entire thyroid gland without touching or disturbing the parathyroid because I said they are close together. So whenever the total thyroidectomy was going on, the surgeon definitely touched, or it's almost impossible to not interfere or to not touch the parathyroid when the total thyroid is taken out. So what happens when they touch this parathyroid, or let's say they damage it? Let me not be using the word touch as if. So when these parathyroids are injured or they're damaged in one way or the other, they cannot perform their function. And what did I say is their function? Their function is to increase calcium levels in blood. So now that the total thyroidectomy process was going on and they were punctured or they were disturbed or they were touched in one way or the other, they cannot perform their function of increasing calcium levels in blood. So the patient runs the risk of hypocalcemia. You get that? And you should know the signs and symptoms of hypocalcemia. Because this question about a total thyroidectomy, they might not just ask you directly. They might use this concept of hypocalcemia to ask you the same question about total thyroidectomy. They might start giving you the signs and symptoms of hypocalcemia, and then that's not to tell you they want to know about calcium. They're not really interested, but they want to see if you understand what happens in your thyroid and the parathyroid that led to this condition. Okay, so some of the signs and symptoms of hypocalcemia, we will do a video on electrolytes. That's a very interesting one. So let me just fast forward the thing. If you see calciums and the prefix says hypo, just know that they'll do the opposite. Hypo stands for low, but when you see the word hypo in the electrolyte calcium, just know that it will do the opposite of hypo. So it will do the hyper things, right? So you will see tetany, irritability, spasms, tremor, and you see paresthesia, which is the very first sign that there's hypocalcemia going on. Paresthesia is the very first sign. And there are two unique signs that happens in hypocalcemia, which is the Trousseau and the Chauvet-Stech sign. I'm sorry if I don't pronounce them the right way. Just try to get the picture of what I'm saying. So these two signs are unique to hypocalcemia, which is Trousseau sign. That's spasm on the hand or on the wrist. When a blood pressure curve is applied, okay, maybe the wrist and the hand, they'll start twitching. That there will be a spasm when a blood pressure curve is applied on the hand. And then the Chauvet-Stech sign, I think these names are either French names or Italian names, I don't know. So the Chauvet-Stech sign is a twitching of your facial muscles, the facial muscles will twitch. I'm sorry, I don't want to touch my face because as you already see, I have a lot of acne going on. I don't know what the problem is. I thought for a moment it was hormonal, but I never used to have them. So guys, if you have any suggestions, I'll be more than happy to welcome them in the comment section so that I can at least look good again. So yeah, I was saying that the Chauvet-Stech sign is a twitching of facial muscles. The facial muscles will be twitching. Okay, all right, so that is it about total thyroidectomy, the removal of the entire thyroid gland, also called complete thyroidectomy. Don't go to the exams and you see total thyroidectomy and you be like, she only said complete. It's the same thing. Complete or total is the same exact thing. Okay. So one thing you must master about total thyroidectomy is this risk of hypocalcemia and how it happens. Now let's go to subtotal thyroidectomy. Now subtotal thyroidectomy means also means a partial thyroidectomy. In this case, the entire thyroid gland is not taken out, just a portion of it is being cut out, okay? So if just a portion is being cut off, these people might need to take levothyroxine. That was the name that I was looking for. So they might need to take this thyroid medications like levothyroxine for just a short while, so that the rest of the thyroid should kick in and start producing the thyroid hormones. Because remember, they did not do a total, they did a subtotal, which means part of their thyroid is still with them. Okay, so they might need this hormone replacement for just a short while, and then the other thyroid, the part of the thyroid gland that wasn't removed, will kick in and start secreting its hormones, and they'll be fine. All right, but remember, for total thyroidectomy, they have to live on this thyroid pills for the rest of their life. Okay, so that's the first thing you should know about subtotal thyroidectomy. Thyroid storm or thyroid toxicosis is something that happens with subtotal thyroidectomy only. Thyroid storm or thyroid toxicosis, toxic thyroid. These things, they are the same thing, and it happens with people who've undergone a subtotal thyroidectomy only. I'll explain. So a thyroid storm, just from the name, a storm, a thyroid crisis, thyroid toxicosis. Wow, that can say a lot, right? Which is why the NCLEX would like to test you on this, because they will not just want to see a nurse who will sit there and there's a patient who has undergone a subtotal thyroidectomy and is exhibiting some signs and symptoms of a thyroid storm, and you just sit there and you don't know, because these people will die in seconds. So you now see why the NCLEX likes to test on this. Remember, they're looking for a safe nurse. So if you are showing them that you're a safe nurse, you need to know what this is. All right? So the interesting part of a subtotal thyroidectomy is this thyroid storm, aka thyroid toxicosis, aka thyroid crisis. All right? So I'll explain how it happens before I will go to the signs and symptoms of this problem, right? So how does it happen? Now, remember how hypocalcemia happened. This guy here called the thyroid storm that happens in subtotal thyroidectomy. It's a different procedure or process from that other one, okay? So in this case, your thyroid is being cut. Part of it is being cut. It's not all that is going away. Part of it is being cut. So in the process of just trying to cut part of the thyroid and leave the rest of the thyroid gland in, there is so much manipulation of the thyroid. You know, the doctors will use the forceps and twist it this way, twist it that way, twist it like this, trying to cut just the portion they want to cut, right? So the process of them doing all that manipulation on the thyroid makes the thyroid to be angry. The thyroid will get angry. And when the thyroid gets angry, it now secretes T4 and T3 it now secretes a lot of this, or excessive secretion of this T4 and T3 into the system. And when this T4 and T3 are excreted in excess amount in the system, this patient goes into a thyroid storm. So do you see why a thyroid storm will not happen in a total thyroidectomy? This is because if I want to cut off the entire thing, this thing, I'll just cut it off and throw it away. But if I have to cut part of this only, I need to make sure that I will cut it at that point where I want to cut it, where it's safe to cut. And so by so doing, I'm manipulating this thing and manipulating it. And by the time I cut off the part that I'm supposed to cut off, the entire thing has been super manipulated, that it stimulated to secrete excessive T3 and T4 into the system. And this is really bad for the patient. Now let's go to the signs and symptoms of this thyroid storm. These are the things you will start to see in this patient that will ring a bell in your mind that, oh my God, this person is going into a storm. The first thing, there will be extremely high temperatures of greater than 105. Extremely high. Okay? Extremely high blood pressures. Extremely high. I'm talking of like 210 on 180. It will be extremely high. Severe tachycardia. Severe tachycardia. And these people are hypoxic. And the fourth sign is psychotic delirium. So if you have a patient that underwent a subtotal thyroidectomy and then you pass by their unit and you hear them say things like, I see a knife behind you trying to stop you, and there is actually no one behind you trying to stop you, please don't ignore, because this is something you didn't expect in someone like this. So if it's happening, think about it. There is something more to come. And these people within the shortest period of time, they can die. So you need to be very, very, very vigilant with these people, okay? So there are 4 signs. I said extremely high temperatures of greater than or equals to 105, extremely high blood pressure, severe tachycardia, there is psychotic delirium. And this crisis, they are called an emergency. Because this hypoxia, remember, the brain is under so much stress due to hypoxia, and they can die in like 2 minutes. Yeah, that's why you have to know as a safe nurse, which explains why boards would like to test us on this aspect. Because if someone can die in less than 2 minutes, then you have to be a safe nurse. Okay, so how do you treat them? So if you start seeing these signs and symptoms, what do you do? Okay, the first thing you do is you get the temperature down and get the oxygen up. Get their temperature down and get the oxygen up. Getting the temperature down, you can either use a cooling blanket or ice, depending on what is easily accessible for you before you wait for the other thing. You have to get the temperature down. Use ice packs or cooling blanket to get the temperature down. And if there was a cooling blanket and ice pack together, you should choose a cooling blanket over the ice packs. But if there is no cooling blanket, use ice packs until your cooling blanket arrives. The second thing is get the oxygen up. You give them oxygen per mask at 10 liters, okay? And then give the oxygen first, of course. So if there is a question about what do you do first, in this case, oxygen first and then temperature down, okay? Yeah. And one thing we need to know about this condition is that it is self-limiting. What we are trying to do is just trying to save the brain for as long as we can so that this T4 and T3 production should stop or should slow down. But this condition is entirely self-limiting. The things we are doing by getting the oxygen up and temperature down, we are just trying to save this patient's brain for as long as we can before the T3 and T4 levels drop to save this patient. It's self-limiting. You watch some of them get out of it successfully and some will not. Remember, the brain is the number one vital organ in your body. So if the brain stops working, if you're declared brain death, if your patient is declared brain death, it means the patient is gone. So that's why we do things that we do by trying to increase the oxygen and then reducing the temperature. All this effort we're putting in is to save the brain. But the T4 and T3 production, it will self-limit itself when the time is right. Okay, so let's look at post-op risk. Post-op risk. So after surgery, for both types, when I say both, I mean for either total or subtotal thyroidectomy, in the first 12 hours, your top priority should be their airway and hemorrhage. You should prioritize their airway and their hemorrhage in the first 12 hours for both types, okay? Now, for 12 to 48-hour window, you need to separate these two. So pay attention to the type of thyroidectomy that was done. So if it's a subtotal thyroidectomy, you should pay attention to what thyroid storm as a complication. If it was a total thyroidectomy, you should pay attention to what hypocalcemia as a complication. And then infection, of course, you can look at that after 72 hours. All right, so yeah. Let's move to hypothyroidism, aka hypometabolism, aka mixed edema. This mix is spelled MYX, mixed edema. So hypothyroidism is also called hypometabolism, also called mixed edema. Okay, so when you saw hyperthyroidism or hypermetabolism, you saw that the person was hyper, right? Now you're looking at the opposite of that person we just looked at. So if you saw a hyper person and you understand what happens with this, and now it should be easier for you to understand a hypo. Okay, so a hypothyroidism, aka hypometabolism, aka mixed edema, you should know that this person, because they are hypo, they will be low. So number one, weight gain or obese. They'll have a flat and boring, dull personality. They'll have low pulse rate, low blood pressure, low respiratory rate, low IQ. I mean, like their IQ is are really, really low. I had a patient with this condition, and I really understand. They have a low IQ. And another thing you see with them is that they'll have hair loss issues. Their skin will be really dry and tough skin. And then another exciting thing about them is they are low. So they cannot tolerate being low again. So they are what? Cold intolerance and heat tolerance. Is the opposite of hyper. Remember? Remember hyper, you cannot tolerate what you are. They were already hyper and they couldn't tolerate being high or hot. So they were heat intolerance but cold tolerance. And these people right here, the hypothyroid people, they are hypo, they are low, they cannot tolerate being low again. So they cannot tolerate cold, but they can tolerate heat. You will find this in one way or the other, which is why I'm really stressing on it, because I want you to ace this question, okay? So hypothyroid or hypothyroidism or myxedema is a low in thyroid hormone, of course. So you need to give them hormones like every day. Levothyroxine is the common one. So my patient used to take this on an empty stomach. On an empty stomach every morning 7 a.m. So they have to take this on an empty stomach 7 a.m. every day. And there's something about these people. So if you receive like a doctor's order that says you should do NPO 12 hours before surgery, and you know that your patient needs to take levothyroxine in the morning because NPO means NPO, okay? You have to question this order. You have to say, hey, look, my patient is on levothyroxine and I cannot skip this at all for any reason. So you have to question that. Remember, BODS is looking at the perfect ward. Okay. Another thing you should not do to this patient, like I said, the first thing is do not skip their levothyroxine. Another thing you shouldn't do for them is do not sedate them. Please do not sedate these people. They are already low. They are already slow. They are already down. You understand? So what happens if you sedate them? You know what sedation does? So if you sedate people who are hypothyroid when they are already, just the condition alone makes them like low, slow, down, and then you want to add to their trouble. Please don't sedate these people. So another thing is when you see a doctor's order that tells you there's a pre-op sedation, blah blah blah, you have to question that because you don't want them to not wake up from the operating table. Because you sedate them and then you give them anesthesia, and then what happens? They will not get up because they're already low enough. It's enough. They already have hypothyroidism. That's enough to bring them down. Okay, then you want to add a sedative. That's not fair. Don't do that. Don't do that. So one thing that will happen to these people if you sedate them when they're already low is they'll go into a mixed edemic coma. Mixed, remember the mix is spelled MYX. They'll go into a mixed edemic coma, which is not good. So be careful. That's why the bot will really focus on these things, because they want you to be a safe nurse. They want you to know those areas that your patient is in serious danger and know what to do, right? Just imagine you didn't know about this and then your patient is sitting there and then there's a sedation going on before the operation and blah, blah, blah. And then the patient never wakes up just because you didn't know these things. You see why content is very important in the NCLEX world? You can guess, yeah, but you will go to the field to practice. What about those patients? What about those people who are dependent on you? Their lives is, I mean, they have given up their decision on their health. It's in your hands, and then you don't know what to do with it, and then they die. Come on. So remember those two things you shouldn't do to a hypothyroid patient. Don't miss their morning pill and avoid to sedate them. So if there's any doctor's order that says these things, question that order. Okay? Question the order. So today we've done the thyroid gland. In our next video, we will do the second gland, which is the adrenal cortex. Sorry. We'll do the adrenal cortex, which is the second gland in the endocrine system, and then we'll be done with the two glands that board will test you on for the NCLEX. Remember, just a recap, in the endocrine system, we're not looking at the entire endocrine system. We're looking at two glands, which is the thyroid gland and the adrenal cortex gland. Today, we've looked at the thyroid gland. I have to go get me something to eat because I'm really hungry. And then in our next video, I will be looking at the adrenal cortex gland. But if you are rushing for your NCLEX, because of course, I know we all have schedules, so I'll advise you to go listen to Mark Klimek, listen to those videos from him, and you will capture most of these things. Like these are my notes that I made, combine my knowledge from different angles, and then I made this notes that I'm using to share with you guys today. And I also not forget him. I passed the NCLEX because of he helped his materials, his videos on YouTube. They helped me a whole lot. Trust me, I didn't buy any material. I didn't buy any of those his books. I just listened to the 1 to 12 two times. If you watch my first video on this channel, you will understand. I said it already. I said I listened to it 2 times. The first time I just listened while on my way to work, and the second time I actually take down notes. And then I did U-Word. So that was it for me. So guys, if I help you with something that that I've helped you with, I would not like you to stop and wait for me to take my entire time to come back and do another video. Just go listen to Mark Klimek, and then you'll be good to go. And do your U-Word. Please don't forget to do your U-Word Q-Bank. Do as many questions as you can. I did the entire Q-Bank, 2,000 plus questions, and then I did the 2 assessments, and then I think I did 500 questions out of the ones that I failed. So I didn't finish the questions that I failed, but I did about 500 out of the ones that I failed from the 2,000 plus that I did. So if I have to sum up the number of questions that I did entirely, I would say close to 3,000. So I was so versed with the way the questions are coming, and then I could easily tell what they're looking for in an answer. Okay. So I'll advise you do U-Word a lot. If you have any other material that you're using, stick to it. Just choose one and focus on it. If you're choosing Mark Klimek and U-Word, just focus on them. There are different mentors. They are doing the same thing, but they're just saying it in different words. So please don't confuse yourself jumping from this to the other. Just pay attention to your mentor. If it's Mark K, or if it's NCLEX Crusader, because those were some people I saw towards the days that I was taking my NCLEX, and I watched 1 or 2 of their videos, and it really helped me. I picked some critical thinking skills that I equally applied in my exam. So you can look at them as well. They're really interesting. and then you can look at other resources that you have at your disposal. But for me, I use Mackay and U Word. So we are wrapping up this video, but I will not forget, please do like it, thumbs up this video, comment. I need to know what you think in the comment section, especially for those of you who know what I can do with this surprise on my face. I never had this growing up until I started experiencing this like 2 years ago. So they come out on the same spot and then come back and come back and come back. So let me know in the comment section what you think. And like I said, don't be surprised if you see some other content on this channel, because it's not just going to be about nursing. I have a really exciting content to share with us. I like to share personal things, personal experiences, my life story. I can write a movie about my life story and how I grew from stage to stage to where I am today. And it's something that can really inspire someone. This might be something I could do in a very long time to come, but I'll definitely share that on this channel. So my journey I will be sharing with you guys, and I would like to carry you along because you're already like family to me, and I feel very comfortable talking to you guys. And I don't think there is any need for me to hold back onto anything. So as my life progresses, we will get to know more and more about me. But until then, good luck for your exams, and you can do this, okay? Don't let nobody tell you that it's difficult. It's not. Put your mind on it and you can do it. God bless you.